Welcome to the ANRCB project's module on introductory concepts in nutrition. In this video, we would like to discuss nutrition for adolescents, adults, and the elderly. We hope that by the end of this video, participants will be able to explain the importance of nutrition during adolescence and its consequences for other life stages. We would like you to be able to describe the importance of nutrition for women of reproductive age, from preconception all the way to postpartum. We also would like you to describe the importance of antenatal, delivery, and postnatal care for mothers. And finally, we would like you to identify changes in the nutritional needs for the elderly. As we get started, I'd like to remind you of this diagram that we've seen previously. Here we're focusing on the life stages from adolescence through adulthood and later in life. For these life stages, we're interested in certain specific outcomes. For adolescents, we're still young. We're interested in development. Children are still developing. We're interested in not just physical, but also cognitive and social and emotional development, as well as school performance. Anemia is an issue that can particularly be relevant during adolescence and during reproductive age, but can also continue on through later in life. And then during pregnancy and lactation, we have additional concerns. So for example, we might be interested in weight gain during pregnancy, maternal morbidity and mortality, and as I mentioned, anemia. We have a range of determinants throughout these life stages that relate to food, care, and health-seeking practices. While these are common overall across these life stages, the nature of these will change. So food and diets or health seeking is different in adolescence than it is in adulthood or in the elderly. So let's start with adolescents. Why focus on adolescent nutrition? There are many nutritional needs of this age group, which ranges from 10 years to 19 years. So for example, you might see and you will find undernutrition in adolescence. This is a challenge, especially for girls in adolescence, where you have high rates of underweight and short stature. This has consequences not just for the young person themselves, but also for them later in adulthood and for girls during pregnancy. You might also have overnutrition, so overweight and obesity, which is increasing throughout the world. Overweight and obesity increase the risk of non-communicable diseases in adulthood and later in life. Adolescents have very high energy requirements compared to people of all other life stages. And they are vulnerable to nutritional deficiencies. They can have poor diets. Young people of this age gain greater autonomy in their food choices, and they have less influence from their parents compared to small children. And so nutritional deficiencies can certainly appear. Iron deficiency and anemia are particularly important. And this is relevant, especially for adolescent girls. There are also a range of behavioral concerns that can relate and influence nutrition. So for example, early marriage. Adolescent girls who marry at a young age are at risk because early marriage often leads to early pregnancy. This can have poor outcomes both for the mother and for the child, with poor outcomes ranging from low birth weight all the way to maternal or infant death. Adolescent pregnancy is a challenge throughout the world and needs to be addressed. Now, the world at a global level has several targets around nutrition and health, and few of these actually focus on adolescents per se. However, there is a contribution of adolescent nutrition to many of these outcomes. So for example, in young children, there is a global target to reduce low birth weight, stunting, and wasting. However, as we just mentioned, adolescent pregnancies can contribute to all of these outcomes. Adolescent girls are at an increased risk of having children of low birth weight, children who are born prematurely, or are small for gestational age. This is particularly true when girls are short-statured or underweight themselves, and this puts both themselves and then their child at risk. Similarly, there is a global target for reducing anemia in women of reproductive age. Anemia and reproductive age starts in adolescence and can be a result prior to a child or an adolescent girl even having her first pregnancy. We also have targets around overweight and obesity for infants and young children and older children as well. And what we find globally is a trend towards increased overweight and obesity, particularly in adolescents in the world. So while the outcomes that we may be interested in are not for adolescents specifically, we can find an important role of adolescent nutrition in contributing towards these goals. Now, there are some promising interventions that have been identified for adolescent nutrition. Some of these are direct and deal with the immediate causes of poor nutrition. So interventions that are generally targeting women of reproductive age are relevant to adolescents, especially during pregnancy. This can include nutrient supplementation, whether with multiple micronutrients or with calcium or iron and folic acid, as we'll discuss further. It could be other forms of food supplementation. It could be fortification, for example, with iodine in salt. It could be general strategies and encouragement to have a diverse and nutritious diet, or it could be to specifically provide nutrient-rich foods. There are other health-related interventions, for example, preventing and treating malaria, providing deworming. And then there are those more broad-based interventions, such as providing education or nutrition and health counseling. There are also indirect interventions. We can think of these are the multi-sectoral interventions. So having reproductive health services that are friendly towards adolescents, this can include preconception care, family planning. The goals here are to reduce unwanted pregnancies, to increase the age at first pregnancy, and to increase birth intervals. We can also think about antenatal care, making sure that if adolescents become pregnant, that they have access since they are at higher risk of complications. There are more broad-based interventions that are possible as well. For example, promoting good hygienic practices, interventions that improve healthy behaviors, encourage healthy behaviors, and lifestyle. This could be towards general health. It could be focused on overweight and obesity. Even more broadly, there are efforts to promote girls' education, which is a major determinant of their nutritional status. We can also think about interventions and programs and policies that will promote economic development, income generation, safety net programs, for example, that might provide cash transfers, and so on. Now, as we move into reproductive age, which begins in adolescence and continues on for several decades, there are increased nutritional needs here as well, and also health risks. So when we think of maternal diets and health and care that are provided for women of reproductive age, these are important even prior to conception. And this sort of care, diets and health are important to have good outcomes for mother, for pregnancy, and for newborns. There are certain stages that we're going to discuss that include preconception, pregnancy, delivery, and the postnatal period. This is often an opportunity because of the contact with health and other systems to introduce interventions that are related to nutrition and other lifestyle factors. Now, one of the biggest concerns around women of reproductive age is anemia. So anemia is identified by a low level of hemoglobin, which is a protein in one's blood that transports oxygen throughout the body. So it has systemic effects when it occurs. This is particularly of concern for women and girls of reproductive age. Anemia is widely prevalent, as I'll discuss in a minute, and it is perhaps 50% or so in globally due to nutritional causes. So this often includes iron deficiency. Most people, and many people will equate iron deficiency with anemia. These are actually related but different issues. Anemia can also be caused by other nutritional deficiencies, such as folic acid, the B vitamins, vitamin B12, for example, vitamin A, C, and others. You can also, however, have non-nutritional causes of anemia, for example, intestinal parasites, malaria, HIV infection. Anemia can also be the result of inherited disorders, such as sickle cell anemia. Now, anemia is truly a global public health problem. This is a map of anemia amongst women of reproductive age throughout the world. And you can see the darker colors are more severe or higher prevalence of anemia. And throughout Africa and South and Southeast Asia, anemia is a concern. In Laos, nearly 40% of women of reproductive age are anemic to some degree. Here's a little bit more information about the global prevalence. The age groups that we are concerned with are women of reproductive age and preschool age children. So that is children under the age of 5. In Southeast Asia, we find very high prevalences. Over half of children under the age of 5 are anemic. We have similar numbers among pregnant women and only a slight reduction in non-pregnant women. Anemia has several functional consequences. This can lead to poor outcomes during pregnancy and perinatally for both mother and child. Even outside pregnancy, there are consequences. So anemia can cause fatigue, it can reduce the capacity of a person to work, it can reduce the capacity of a younger person to learn effectively in school, and in general be less productive. It can also have mental health consequences, and that's a serious concern, whether that applies to women who have children or broadly at all ages and life stages. Mental health has a link with anemia. It can affect immune function, it can lead to increased morbidity, and severe anemia can have other more acute effects. One part of the cycle around reproduction that is getting increasing awareness and attention is the periconceptional period. So this is the period that is before, during, or after conception, and includes placental development and early fetal development. So what's important here is both, especially in maternal nutrition, this is relevant for both the mother and the fetus. This is a critical period where many women may not know that they're pregnant and they may not yet seek out antenatal care. During this period, specific nutrition is needed, especially to support early fetal development. Certain nutrients are key here. Probably the most important that you may be aware of is folic acid. Others such as iron, zinc, and vitamin B12 are also key. During pregnancy, antenatal care, or the visits, the routine visits that women undergo during pregnancy, are aimed to protect both her health and the unborn child. So here, there is an opportunity for pregnant women to learn from skilled personnel about healthy behaviors, and for those skilled personnel to identify and check for warning signs during pregnancy and childbirth. Antenatal care involves screening and monitoring, but it should also include social, emotional, and psychological support. So this sort of routine periodic care is an opportunity for women to access micronutrient supplementation, screening and treatment of hypertension, of gestational diabetes, and other issues. They can receive important immunizations as well. Previously, the recommendation has been a minimum of 4 contacts during pregnancy in which a woman is provided antenatal care. More recently, this recommendation has been increased to a minimum of 8 contacts or interactions with the antenatal care during pregnancy to lead to better perinatal outcomes. Here are some data about antenatal care visits by women of reproductive age. And what we see here, let me point here. We can see some statistics. Here's South Asia and here's East Asia. This is the percentage of women that receive either at least one antenatal care visits or at least 4. And what we see is relatively low numbers. So for example, in South Asia, only about half of women have 4 or more antenatal care visits. Excuse me. Now, there are several interventions that are delivered. Data can vary from country to country. So here's a recent summary of various interventions that relate to pregnancy, delivery, and young children. So for example, here under pregnancy, let me use a pen. Under pregnancy here, we have 4 or more antenatal care visits, and then iron and folic acid supplementation. So here for these 2 outcomes, we have data from 17 countries. The blue bars are the period from 2008 to 2012. The pink bars are from 2013 to 2018. And what we find is about 2/3 of women overall in these 17 countries having 4 or more antenatal care visits, and then maybe only 1/3 that is receiving iron and folic acid supplementation. We see here also another recommendation is to deliver in a healthcare facility. There again, the numbers are around 2/3. There has been some improvement over time here, but promotion, for example, of early breastfeeding, much lower and not much improvement over time as well. So one important thing to note is that there are opportunities for improvement. Certainly we want to improve these over time, and we haven't seen very much progress for several of these outcomes. Also, the women who receive antenatal care should be able to receive iron and folic acid supplementation. So the difference between here and here presents an opportunity gap that can be addressed through policies and through efforts. Now, the recommendation during pregnancy is moving toward away from iron and folic acid supplementation and in support of providing multiple micronutrients beyond just only iron and folic acid. So the most latest recommendations have been to do this multiple micronutrient supplementation. There has been pretty good evidence that shows that providing multiple micronutrients can reduce the risk of stillbirth, of low birth weight, of small for gestational age, and preterm birth, shown in multiple studies throughout the world. Now, care during delivery is also essential. This should be provided by skilled health personnel, and this is important to reduce both maternal and newborn morbidity and mortality. Throughout the world, there has been some progress in having skilled birth attendants. About 83% of births are assisted in this way. Now, when I say skilled birth attendants, this can include medical doctors, nurses, or midwives that are trained to handle normal, uncomplicated deliveries. So while they may not be able to provide all services, they will be able to recognize complications in a timely manner. For example, if there's evidence of hemorrhage or sepsis, these very important and leading causes of morbidity and mortality, if those can be recognized and appropriate referrals and actions can be taken, that can really improve perinatal outcomes. But still, we have millions of births throughout the world that happen without the assistance of any kind of skilled attendants. Here is a map of the world where we have the percentage here. The lighter colors represent higher percentage of births assisted by a skilled birth attendant. So still we see some challenges in Africa, in Southeast Asia. In Laos, about 2/3 of births are attended by a skilled birth attendant. So there is room for progress here as well. Here's a few more numbers of skilled birth attendants. And again, we see really useful and helpful improvements. The different colors here represent a time from the year 2000 up to the year 2020. And so we see rapid gains, for example, in South Asia, but yet still work for us to do. Now, when we talk about perinatal outcomes, we often focus on mortality, both of mothers and of children. But maternal morbidities are also very important. So recent work here around the prevalence and consequences of maternal morbidities have really showed us the importance of this. So this study involved collecting data from multiple other studies to have data on the results of pregnancies, over 100,000 of them in South Asia and Sub-Saharan Africa. And here they looked for specific morbidities, including hemorrhage, hypertensive disorders, infections, obstructed labor, and so on. And what we found were exceedingly high numbers. So what we have here is total numbers, percentages, and then a 95% interval for these estimates. And so in South Asia, 44% of pregnancies had at least one of these morbidities. In Sub-Saharan Africa, it was actually lower. About a quarter of pregnancies had one of these morbidities. And what we find is that having these morbidities increases the risk of stillbirths and of mortality of both of the mother and of the neonate. So postnatal care is another component of this that can reduce some of these adverse outcomes. So this is really another critical phase. What we find is the majority of mortalities occur in that kind of neonatal period within the first month after birth. And so there are guidelines around postnatal care. So the ideal would be for a woman to deliver in a health facility and to have at least 24 hours in that health facility prior to discharge. If there are home births, then that mother and child should be visited within that first 24 hours, and care and evaluation should be provided. Home visits can be done by skilled providers of various sorts, whether they're midwives, if they're well-trained or supervised community health workers, that could also be a possibility. There's also several visits that are recommended early in a child's life. So within the first day, within the first week, and within the first 6 weeks or so of life. Another issue for women during pregnancy is weight gain. So pregnancy is naturally a period of rapid weight gain and changes in body composition. The amount of weight gain that should happen depends on a mother's body mass index prior to pregnancy. So the less that a mother weighs, the more underweight she is, the more that she should gain weight during pregnancy. So for example, if a mother is underweight, we would hope that she would gain 12 to 18 kilograms during her pregnancy. As you move higher in weight, so that if a mother is overweight or obese prior to pregnancy, we would expect and aim for less weight gain. And that would be the recommendation. And this is all to ensure a lower likelihood of complications with delivery, and with consequences for the child, both immediately and also later in life. It is very true that a healthy diet is certainly central during pregnancy. Women should be consuming extra calories than when they are not pregnant. After delivery, another concern for a woman's health is postpartum weight retention. So there should be weight loss after pregnancy, and excessive weight gain during pregnancy can lead to this larger retention of weight after delivery or after postpartum. Retaining weight postpartum can have negative effects on maternal health. It could lead to future overweight and obesity, and non-communicable diseases. Certainly some lifestyle behaviors such as suboptimal diets, low physical activity can contribute to the retention of postpartum weight. One thing that is conducive and that assists in weight loss is a longer duration of breastfeeding. So in this graph here, let me show this to you here. What we see here is weight retention. So what the ideal scenario would be to see this loss of weight after pregnancy, after delivery. When the duration of breastfeeding is relatively short, for example, under 3 months, what we see is this retention of weight. However, if there is prolonged breastfeeding, that will help in weight loss. So that leads us to some of these consequences of overweight and obesity. These are issues not just for women, for adults, really throughout the life course. This is becoming an increasing concern. And the concern really regarding overweight and obesity is that it can increase the risk of other health problems, either now or very likely more into the future in one's life. These are for non-communicable diseases. These things can include cardiovascular disease, diabetes. It can even certain forms of cancer you can have increased risk due to overweight and obesity. In Laos, about half of deaths that are recorded in Laos are associated with some non-communicable disease. This includes cardiovascular diseases and cancers. It's possible to lower these risks by having healthy lifestyle behaviors, healthy diets, and physical activity. Now, how do we assess nutritional status as we talk about all these different life stages? So certainly the methods of assessment depend on life stage. So for example, when you're dealing with very young children, you might use anthropometry. Anthropometry, measuring various parts of the body, such as height or weight, some of those are appropriate throughout the life course. Others are more typically used for very young children. For example, children under the age of 5, you can assess head circumference or middle upper arm circumference. For older adults, for non-pregnant women, we can consider the body mass index, waist circumference, hip circumference, or the ratio of waist to hip. Those are all useful indicators. Weight gain and mid-upper arm circumference are also common during pregnancy. We might also use biomarkers as well. These can indicate both undernutrition and underweight, but also overweight and obesity. And again, signal that risk for non-communicable diseases. Now, as we move on into older populations, populations throughout the world are aging and are projected to age in the coming decades. And so this presents a significant burden on health systems and social systems throughout the world to make sure that the needs of populations are met. The determinants of nutrition in the elderly are both individual and broader. So we can think of health behaviors. There are changes that happen, thinking musculoskeletal and other kinds of metabolic changes. There can be genetic determinants here, diseases over time that are both infectious, but also in particular non-communicable. But then there's the larger context in which all people live. So the quality of housing, the services and social facilities, access to care, to transportation, to assistance, all of these things, and several others affect the nutrition and well-being of elderly populations. Certainly, nutrition is also important for an elderly population. Nutritional needs change as people age. And all of these affect quality of life, and that includes physical, mental, and social health. So a broad view and definition of health and well-being. In general, requirements do decrease, but it is important to maintain, again, a healthy diet, because there can be a reduction in eating that can lead then to nutritional deficiencies. These might be micronutrient deficiencies. It might be related to wasting and loss of muscle mass in particular. It could be anemia as well. So they're definitely the same nutrients, both macro and micronutrients, as you can see here, that are important for maintaining the body and the needs for the well-being of the elderly. So we've talked about many needs throughout the life course here. A lot of these needs are well known, and there is a good evidence base of new actions and interventions and policies that can be taken to improve nutrition throughout the life course. These have been documented and are referred to often as the essential nutrition actions. So these are ones where we have a strong evidence base. We know that they can help the nutrition of populations. Many of these recommendations take a life course perspective, starting from infancy all the way until older age. Most of these actions can also be delivered through primary health care, but can also require a multi-sectoral approach. So let me show you some of these essential nutrition actions. Here's the beginning of a table that will describe these both overall and through the life course. So there are a few interventions, for example, having a healthy diet that go across all life stages. But others that are targeted. So for example, if we're talking about infants, we can talk about timing of umbilical cord clamping or promotion of breastfeeding, for example. These are relevant to all infants. However, there are also at every life stage, and let me show you here, certain things that might be targeted to specific populations. So for example, handling low birth weight, assessing and managing wasting in children, providing supplementation, and so on. Similarly, as we start looking at children, appropriate complementary feeding is important for all young children, but there might be also targeted things as well. And this continues. We have a reference here if you're interested. So another part that is important here is to recognize that many of these can be delivered through primary health care, right? Very few of these, such as management of acute malnutrition, for example, require specialist care. This is really a job for primary health care. However, it's not only for the health sector. In many cases, there are other sectors that are also involved. These can include agriculture, education, trade, water, and infrastructure, other kinds of social protection, and so on. Okay, so we have covered a lot of material here. To summarize, we can see after this module and the previous one, nutrition is truly essential throughout the life cycle. Optimal nutrition during adolescence and prior to those reproductive years benefits girls at the present moment, but also later in their lives as they become adults. But it can also have intergenerational effects and benefit future children. We know it's well known that pregnancy is a critical period, and there are specific needs during pregnancy for the well-being of mother and child. But also important are the times before conception and around the time of conception. Nutrition at those stages is also important, and it's important for us to think of strategies to reach women during those stages. During pregnancy, proper care includes antenatal care, delivery care, and postnatal care. This is, again, important for mother and child for both mortality and morbidity. And then finally, the elderly have also different but important physical and mental health needs, and this includes nutrition. Okay, so this concludes topic 4 of module 1. Thanks very much for your attention.